I'm going to talk to you about how if you put a stent in without IVUS. And because we made a great push to have everyone use IVUS, but I'm going to show you this case. This is a case of a young man who had an ulcer on this leg. He had one starting on the other leg as well. He was only 22 years old. He was born premature, hypertrophic left kidney. He was a preemie, so he may have had a line when he was a very young baby. He developed bilateral DVT in his iliofemoral and IVC DVT as well. So by the time I saw him at 22, he already had an ulcer on one leg. So this is his initial venogram. You can see that he had DVT, chronic DVT in his iliac veins, a lot of collaterals around his cava. He had chronic thrombosis in his cava as well, up to the renals at least. It was a huge project to help this kid, open him up, and I'll show you what happened when we put stents in him. We did it with urokinase, lytic therapy dripped with catheters like we did, and this was done in 2002. Well, it looked pretty good there, and we did all right, and that's the view of the CT scan showing his wall stent up in the upper cava. Down below there were two, but then I put I put a wall stent in the suprarenal cava just because it seemed like it was still narrow. Now, that was a misconception on my part because when there's not a lot of flow going up through the cava is not expanded. And that was quite near the heart, but I thought I was doing the right thing. So the case went well. He felt okay. We sent him up to the ward, to the ICU, I guess. And I got a call like at about 5 o'clock in the morning saying that he didn't feel good. He was coughing. He just felt sick. And so I think, well, the most likely thing would be maybe a retroperitoneal hematoma. He doesn't want to do it. We'd check that out right away. So I went to the CT scanner right there at 6 o'clock in the morning. And this is what we saw. And like I couldn't believe my eyes that his stent was in his heart. And so, I mean, you can imagine how I felt, 6 o'clock in the morning. And I called Dr. Castaneda, who had trained me in Minnesota. And I'll never forget what he said to me. He said, "Get that sucker out of there." I said, "Yeah, I know. Any suggestions?" Well, I got everybody that I could involved. I got the cardiovascular, I was a cardiac fellow now, the vascular surgery fellow. I got the cardiologist. I got anesthesia. And by 6:30 in the morning, we had him into the cath lab. And he did, in fact, have a fusion around his heart that had to be evacuated first. And then we went in through the right jugular. We went in through the right and left femorals. We had 3 sheaths in him, a very large sheath up here in the neck. And we had the snares. And you know, it was very, very difficult to catch that stent because it was bouncing around. And I'm telling you, it was one of the worst experiences I ever had. And so I became dedicated to making sure I knew how to size a stent and keep it in the right place and not ever have it migrate. So very few people had admitted to this kind of disaster. I've shown this around the world, but it was an experience to me to teach me that I'm responsible for that not happening. And you know, the stents now that are smaller and more rigid than a wall stent will cause a lot more damage to the heart valves if they migrate. So I'm going to show you a little bit about a study for that. But why do stents migrate? Because they're not attached to the wall well enough. Well, how do you attach them to the wall well enough? You have them be the right size when they expand so they touch the wall, and then you have them be long enough so there's enough apposition to the wall. They don't have the tendency to go flying off if the patient valsalvas or coughs. So if the stent's too short or too small, you're going to have a problem with the stent migrating. no IVUS. Well, we didn't have IVUS for a long time. So we put a lot of stents in without IVUS. And people still do. There are a lot of people now that say, I don't need IVUS, I can do this, I can figure it out. I'll just look at the iliac and figure out what I need. But the things I came up with before IVUS, which was in about the late 90s, early 2000s, was the visualization from the venogram. If you do an LAO 30, you don't see too much, but when you go over to 60 degrees, then you can measure the upper part of the vein, the iliac vein, and the lower part more readily, and you can get an idea of how narrow your compression is. That helps you a little bit. You can get a CT scan and you can measure. A CTA, I find, is very useful, so you can do measurements of the veins and the compression, so that gives you an idea of how you have a case that warrants a stent. And of course, the left leg here is larger, so you know that that's where the compression is. But still not enough to try to figure out what to do. So when we were in the Vici study, I spent a lot of time trying to figure out how to make sure there was never any migration. And I'll show you what we came up with. The wall stent choices then, before the Vici, we know were between 40 and 90, and we usually would put a 90 and a 60 and a 90 if we had to stent from the bifurcation all the way to the inner trochanter. And our choices were only 14, 16, and 18 for usual cases. Very few people needed a 20 to 24, and they're shorter anyway, so that's a problem. So stenting is, in an easy case, is easy, and when they get a little more odd, then you have to be very careful about your stents not migrating. Well, Dr. Murphy has a wonderful article out about having reviewed the Aubrey cases that went in, the Aubrey stents that went in. There are 200-some patients that they reviewed. And it's a very good article. I recommend it to you. And she didn't have any cases where they documented a migration with the Aubrey. So the Aubrey has a way of opening up and opposing the wall, especially if you have it wide enough. So what are the major warnings? No short, wide stents. People have migrated, the stents have migrated when they're short ones, 40 or 60 up in the common iliac, and there are not enough wall apposition. Stents should overlap a little bit. If we use wall stents, we always overlap them a little bit. Sometimes with the Aubreys and the longer stents, you don't have to. And the Aubrey stents go down to 100, 110, 150. Stents should be long enough, so a short stent system in an iliac is not a good thing. Well, there's no benefit if a stent matches the length of the common iliac vein. It's too short, and it needs to extend longer into the external iliac, in my opinion. There's no harm if you have a stent that is not quite as wide as that pre-stenotic dilatation, and that's what confuses a lot of people. It's narrow where the compression is, or the artery is sitting on the vein, but below that, it's pre-stenotic dilatation, and it's abnormally wide. But you don't have to size your stent to that width, you just have to put the stent through it. So there's continuity of flow from below that area to the cava. And there's no harm if you extend the stent all the way down to the external iliac vein where it looks normal. So I want to give you this concept. This was in the lab when I worked with Vici to try to figure out what it takes to make a stent migrate. It's a certain amount of pressure and a certain lack of attachment to the wall. And it's called the dislodgement of force. That's just a scientific format, but this is how we figure this out. And you can use it if you want to, and it's very useful. But if your stent touches, is this a, let's see where the, you're going to have to follow me down. I don't have a pointer here. If your stent touches the wall at least 62% of the distance that you're dealing with, you will not lose your stent. Less than 62% has been the bad spot. Above that, more than 62% of the stent touching the wall will assure you that your stent is going to stay in place. So if you want to, you can always say how many times on this wall, and you go 1, 2, 3, 4 down the wall, will a 14 millimeter stent touch the sidewall? Well, a 14 will touch at 5.6, but not at 18.2, at 7.4, but not at 22.3. So you see the 22.3 represents the pre-stenotic dilatation. And from front to back, the stent is really small, 7.4. So when you take your measurements with IVUS and you put them in this little grid, you can count with a 14, 16, or 18 millimeter stent how much percentage you'll have, and that'll give you assurance that your stent is going to stick to the wall. And you can see with a 16 millimeter stent, you're over 62%, and with an 18 millimeter, you're 75%. The difference between 66 and 75 is negligible because once it's stuck to the sidewall, it's not going to move that well. It's only when it's below 62%, and that's been proven a lot in cases and experiments. So I grant you that if you do the counting and you say, will this stent touch the wall if I put in a 16 or a 7, an 18 or a 14, then you will have the information you need. This is a systematic review of venous stent migration that was recently put out by the people at Yale. Rob Adaran and his group at Yale looked at 73 papers and 84 patients. And they concluded that the stent migration to the heart was not insignificant. It was 12%, required surgery, and 3.6% died. 3 patients died of having a stent migrate. And a number of these were from dialysis situations where they put them in the arm, and then some of them were from nutcracker syndrome where they did the renal vein, and some were from iliac stenosis. So, in conclusion, you don't have to use IVUS, but you should use IVUS to be careful and safe for your patient. Because if you kill a patient by stent migration, that's a bad situation for the family, for the patient, and for you. The risk of stent migration is much less with longer stents and accurate sizing. So the fact is that these stents, we started doing them and doing them without IVUS, but if you do IVUS, it's safer. And I think it's our responsibility to make sure that we don't kill people with a complication with the stents. So it's a kind of an ongoing study, but I wanted to share with you what I know about not migrating a stent, or not allowing it to migrate. Thank you.